Good morning, everybody. I've been given this pleasant duty to introduce our guest speaker today, Dr. Vanita Rahman. She's an NRI American physician and a board-certified specialist in internal medicine and lifestyle medicine, and also a certified nutritionist. I want to tell you that she was born and brought up in India and born in New Delhi. She had her schooling in Bangalore, and then she did her undergraduation and post-graduation from the University of Virginia. So what is PCRM? And she is the Clinical Director of Physicians Committee for Responsible Medicine. And the Physicians Committee for Responsible Medicine is a non-profit organization which is based in Washington, D.C., and it actually conducts clinical research as well as provides nutrition education. And we are very happy that she has spared her invaluable time to discuss with us about the role of nutrition in reversal and prevention of various non-communicable diseases. And in addition to that, I think it's so important for all of us to understand that these diseases have reached epidemic or pandemic proportions because of the worldwide, there's such a high incidence of obesity. 1 in 8 people are obese, and we think in India being a developing nation, I think now we are developed, but we have a large chunk of population which is relatively poor, can't afford good diet, but we still see that we are seeing diabetes and all really flare up in our country, and the incidence is increasing. So it's important to understand the reasons that why is diabetes, why are these non-communicable diseases increasing in our population. So though at one end we suffer from undernutrition and malnutrition, at the other end we have this a huge increase in the number of people who are overweight and obese. And ma'am, we look forward to your talk today on the role of nutrition in the prevention and reversal of non-communicable diseases. I would request Dr. Ambuj to welcome ma'am with a potted plant. So chairing the session today, we have a professor of cardiology, Dr. Ambuj, who also is the professor in charge of the SET facility. And we also have the chief of dietetics department, Dr. Parmeet Kaur. So ma'am, may we begin the talk? Dr. Vanita Rahman.
Should I start? Okay. Well, good afternoon, everybody. Thank you so much, Dr. Rima, for the introduction, for arranging this, and Dr. Ambuj and everyone else for being here today. This really is my hometown. I was born here. I spent every summer here, very close to here in Green Park with my family. So it's wonderful to be here in a clinical capacity today. I noticed when I pulled into the campus, signs for World Kidney Day. And this is really apt timing because we know diabetes, hypertension are the leading cause of kidney failure around the world. And these are all non-communicable diseases that are heavily influenced by lifestyle. So what I'd like to share with you are scientific research studies and helpful data and resources to help you take care of your patients. This is an outline of the lecture today. We'll start with a clinical case, nutritional trends in South Asia, and then talk about obesity and overweight, diabetes reversal and prevention, cardiovascular disease reversal and prevention, and then talk about some nutrition myths, and then we'll leave time for question and answer. Okay. Now, let me ask you in the room, how many people think diabetes or obesity or cardiovascular disease are irreversible, that once someone develops them, there's no going back? How many people believe that? Can I get a show of hands? Nobody in the room? Maybe one or a few people? It is reversible. So how many people think it can be reversed, these conditions? Yeah. And that is the good news. These are not genetic conditions that we have to succumb to. We can change the trajectory. And that's what I'll share with you today. So I'll start with a true patient story. This is a patient of mine who came to see me, 55-year-old woman with severe obesity, and she had just been diagnosed with type 2 diabetes. Her BMI is 45. Is everyone familiar with the BMI scale? Yes? Everyone familiar with A1C? Yeah. and her A1C is 12.7%. So this is really out of control diabetes. And her primary care physician had told her she would need insulin the rest of her life, which really frightened her. She could not have walked around this room when she met me. She was in really poor shape. So I discussed with her the various options and went through the pros and cons. Are you using GLP-1 agonists? Yes. So this was one option. Insulin. How many people would pick one of those? Metformin. So how many people would recommend that for her? Yeah. How about metformin plus something like glipizide or glyburide? Yeah. I could refer her to a bariatric surgeon. Her BMI is quite high. Or we could explore diet and lifestyle changes. Well, she came to see me because she didn't want to take medications and she did not want to have surgery. So she said she's willing to do anything to reverse this. So I suggested she try a plant-based diet, which is what I'll discuss with you today, and lifestyle changes. And let me share with you how her health improved. So she started out at baseline with a BMI of 45, A1C of 12.7, 134 kilograms. In 3 months, without any medications, her A1C had dropped to 6.7. So we know that it's hard to do that even with medications. We can give people insulin and lots of it, but then they don't like the way they feel with insulin. They don't like the injections, they gain weight, which makes the glycemic control worse, paradoxically. Then another 5 months later, she continued along this path. Her A1C had dropped to 5.8. Another 3 months later, it is now 5.7. So her diabetes is essentially in remission. She's lost significant weight. She still has a lot more weight to lose, but her health has improved. And she's now walking 3 kilometers every day. So this was really a life-changing experience. And we see patients like this all the time in our clinic. So how many people think nutrition is important in our health? Yeah, very important. And this study showed that in 2017, 1 out of every 5 deaths was attributable to poor nutrition. And the researchers went on to conclude that poor nutrition is responsible for more deaths globally than tobacco, high blood pressure, or any other health risk factor combined. So this is how important it is. We can prevent 20% of premature deaths just by changing the food on our plate. Now, I think most of you already know this, but diet and lifestyle impact our weight, our blood pressure, our blood sugar, our cholesterol, how well we breathe at night, whether we have sleep apnea, and all of these conditions in turn impact our risk of cardiovascular disease. What is the leading cause of death in India? Anyone want to shout it out? Yeah, cardiovascular disease, leading cause of death not only in India, but around the world. So how many people are familiar with plant-based diets? Can I get a show of hands? How many people are familiar with vegetarian diets? Right? How many people know the difference between the two? All right, well, that's what we're going to explore today. So usually when I say plant-based diet, this is what people think of, and they feel very disheartened. But actually, this is what plant-based food looks like. These are all food items that I prepared and that my family eats regularly. Now, at the Physicians Committee, we have developed a power plate to guide patients and healthcare providers. And you can see the power plate is really quite simple. There are 4 food groups that are familiar to all of us in this room. Fruits, vegetables, legumes, which are pulses, lentils, that are quite common in India, and grains and vegetables. So we know these foods. And what we do in our research studies when we prescribe plant-based diets or when I see patients in the clinic is we recommend they eat these foods and eat lots of them. And we recommend they avoid all animal foods, including dairy. minimize oil and fried foods, and I'll explain why in a little bit. And if someone is looking to lose weight or lower their blood sugar, important to minimize plant foods that are naturally high in fat, such as coconut, nuts, seeds, olives, avocado, and minimize simple sugar. So we don't advocate for no added sugar, but we do recommend minimizing it. So fruits instead of fruit juices, avoiding sodas and sugar-sweetened beverages, such as mixed drinks. And then we recommend everybody take a B12 supplement daily. So all the research studies that I'll be sharing with you, this was the diet that was prescribed. And the best part is we don't ask people to count calories or count carbs. We tell them to eat till they're no longer hungry. And people really like that. It's simple. Now, this is what the macronutrient breakdown looks like. People who are looking to lose weight or improve their diabetes are often told to avoid carbs. Have you heard that? Avoid carbs? When in fact, research shows the opposite to be helpful. So it is a high carbohydrate diet. About 80% of the calories are from carbohydrates, 10% from fat, and 10% from protein. So how do plant-based foods promote health? Well, first of all, how many of us are familiar with fiber? And is fiber healthy for us? What do you think? Yes, we all agree there, right? But maybe people may not be aware is that fiber is only found in plants. This is what apples give. This is what gives apples their crunch, or carrots their crunch, or why leaves feel rigid. The stems snap when we break them. On the other hand, animal foods do not have any fiber. Now, plant foods are also low in cholesterol, have zero cholesterol, whereas animal foods, all animal foods have cholesterol in them. And dietary cholesterol increases our cholesterol levels. The fat content of plant foods is generally low. The fat content of animal foods is high. The reason I emphasize that is plants, because they have fiber, which has no calories, and they have generally low fat, their caloric density is low, so it helps promote a healthy weight. On the other hand, animal foods are very high in caloric density. And then plants are full of antioxidants. We know free radicals occur in the body. They cause infection, inflammation, disease. Plants are rich in antioxidants that neutralize them. Let me ask you, how many of us are aware that tobacco causes cancer? Okay. How about asbestos causes cancer? How many of us are aware that processed meat causes cancer? Great. The World Health Organization has said that processed meat is a group 1 carcinogen, just like tobacco and asbestos. However, tobacco comes with a warning label, right? Processed meat does not. So we have a lot of work to do in public health. And the World Health Organization has also said that red meat is a probable carcinogen. Okay, I just went through how plant foods are important in health, but what's been going on in South Asia? Well, this is our traditional Indian thali. This looks familiar. Every state in India has their own version. What do you see on there? It's kind of similar to that power plate I showed you. There are lots of fruit, vegetables, legumes, grains. This was our traditional thali. However, it was made with lots of natural ingredients, roti, and we brought it all together with herbs and spices. But the food is changing in India and all of South Asia. Look what's moving in. Fast food. Western fast food is taking over. This is a typical mall in Mumbai where I took these pictures. And there were more fast food establishments. I just couldn't fit them all into this slide. But it's not just Western fast food that's moving in. Our Indian food is changing. This is what food looks like commonly in South Asia. Now, what do you notice here? What is this food? What do all these food items have in common? Fried. Fried food, added oils, fried food is taking on a more prominent role than ever before. And combined, this is making a big impact in our health. We see that in South Asia as fast food consumption, added oils, added sugars, dairy products. The consumption of these foods is increasing. The consumption of those traditional Indian foods is going down. The whole wheat rotis, the rice, the vegetable legumes. And as that is happening, we are seeing this epidemic, or as Dr. Rima said, really a pandemic of non-communicable disease. Obesity, hypertension, diabetes, dyslipidemia, cardiovascular disease. We could add chronic kidney disease to it. We could add Alzheimer's to it. Inflammatory bowel disease, autoimmune conditions. They're all rising rapidly. The trend in South Asia has been that the risk of communicable disease or deaths from communicable disease is going down, and deaths from non-communicable diseases are increasing. Now, I want to take a minute to talk about us as South Asians and the unique risk that we face. Now, research has shown conclusively that as South Asians, we have a unique body composition. And South Asia comprises of India, Pakistan, Bangladesh, Nepal, Sri Lanka. Some people lump Bhutan and Maldives into it, but it is home to 25% of the world's population. And what we know is that, based on body composition research that I'll share with you, that South Asians carry more body fat, especially visceral fat, hepatic fat, pericardial fat, and carry less lean muscle mass at any given BMI than other races. And this is really important because it's really that visceral or hepatic or pericardial fat that influences our risk of chronic disease. In fact, this is an ongoing research study that's been published. It's going on in the US. It's called the Masala study, where researchers at Northwestern University and University of California, San Francisco, along with the Harvard School of Public Health, are looking at the body composition of South Asians in the US and why their risk of chronic disease is greater. And what they're discovering based on CT scan analysis is more hepatic fat, more intermuscular fat, less lean muscle mass. Now, everyone here is familiar with BMI, but I wanted to draw attention to the BMI scale. So in the first column, you see the standard World Health Organization BMI scale, usually applied to whites, blacks, and Hispanics. You see that overweight starts at a BMI of 25, obesity at a BMI of 30. But look at the World Health Organization criteria for Asians. They said Asians as a group carry more abdominal fat, more body fat, so their BMI is considered obese at 23, overweight at 23, obese at 27.5. But then in 2009, Misra and colleagues published this paper, which was a consensus statement issued by Indian health experts saying, wait a minute, even that BMI scale isn't right for Indians. We carry so much more body fat and abdominal fat at any given BMI that our risk starts to climb much earlier. So they defined obesity as BMI of 25 or more and overweight of 23 or more. And this is really important that we classify people's BMI correctly. And the Masala study that I spoke to you about has actually shown that they have been tracking high blood pressure, elevated lipids, and glucose in South Asians. And what they found, and they've been comparing these 5 different races. And what they found is that when they look at European populations, they start to develop these complications at a BMI of 25. For African Americans, 22.9, Hispanics, 21.5. But look at where we are as South Asians. At a BMI of 19.6, we start to run into cardiometabolic trouble. And that's, again, because of our unique body type. And research has shown that South Asians develop diabetes and cardiovascular disease 10 years earlier than other races. So what is the prevalence of cardiometabolic conditions in India? generalized obesity, it's 28.6%. But look what's interesting. Abdominal obesity, the prevalence is actually higher, nearly 40%. So it's possible, just based on BMI criteria alone, we're missing people with abdominal obesity, which is the real culprit in chronic disease. And you can see the prevalence of various conditions, but since India is home to nearly 1.4 billion people, when you put these percentages into absolute numbers, they're really staggering. Over 100 million people with diabetes, over 136 with prediabetes, and the number that really caught my eye is 81% of Indians have an abnormal lipid profile. So it's uncommon for someone in India to have a normal lipid profile. And this all goes back to our predisposition. So let's talk a little bit about obesity management and reversal, because it's really front and center in the beginning of chronic disease. Now, this is a randomized controlled trial that our team at the Physicians Committee did. We took persons who were looking to lose weight, and we randomized them into two groups for 16 weeks. One group ate their usual diet, the other group ate a low-fat plant-based diet, like the one I shared with you. And look what happens at 16 weeks. The weight goes down 6.4 kilograms in the plant-based group, just half a kilogram in the control group. Now, everyone had a DEXA scan before and after the study to assess body composition. And what we see is a majority of the weight loss was body fat. So 4 kilograms of body fat was lost. Cholesterol levels dropped nearly 20 points, and LDL levels dropped 15 points. Now, we did another study. How many people are familiar with the Mediterranean diet? So it's been touted as a heart-healthy diet, and for good reason. In the 50s, a researcher named Ansel Keys from Minnesota traveled to the Mediterranean to see why are the risks of cardiovascular disease lower in the Mediterranean. And did you know at that time, when that Mediterranean diet was originally studied, it was over 90% plant-based. And now it, of course, doesn't look anything like that. But we did a study to compare how a Mediterranean diet stacks up with a plant-based diet. So we randomized people into two groups. One group consumed a Mediterranean diet, the other group consumed a plant-based diet. And when we look at the numbers, there was no weight loss in the Mediterranean group, 6 kilogram weight loss in the plant-based group. Again, most of it is body fat from DEXA scan analysis. Cholesterol dropped nearly 20 points in the plant-based group, and there was virtually no change in the Mediterranean group. This is a study from New Zealand that the research team did, randomizing people in the community to a plant-based diet or standard care. And what we see is at 12 months, the average weight loss in the plant-based group is 11 kilograms, so significant. Virtually no weight loss in the standard care group. The BMI dropped 4 points in the plant-based group. The cholesterol went down 20 points again. The LDL cholesterol dropped 23 points, and hemoglobin A1C dropped half a percentage point. So we're seeing improvements across the board in cardiometabolic parameters. And when the research team looked at how people were managing the diet, they found that at 6 months, there was no significant difference in food enjoyment, cost, or exercise. Let me talk a little bit about diabetes management and reversal. This is a research study that Dr. Neil Barnard, who's our founder and president, did. This was funded by the National Institutes of Health. And he took people with type 2 diabetes and he randomized them into two groups, a portion-controlled or American Diabetes Association type diet or a plant-based diet. And this is what the intervention looked like. Portion-controlled group was advised to limit calories, keep carbohydrates steady, limit the bad fats. And the plant-based group was advised to avoid all animal products, minimize oils, consume foods with a low glycemic index. And let's see how they did. So if we look at their A1C, At 22 weeks, this is the control group. Their A1C went down a little bit, 7.88 to 7.5. But look what happens in the plant-based group. They go down significantly more, 8.07 to 6.84. And again, this is without any medication changes. Yes? Correct. So the plant-based group was advised to avoid all animal products, including dairy. Yes, definitely. All of these together, and I'll explain why in just a minute. This was a study published from South Korea where the team did a similar study for 12 weeks, a randomized control study. They took people with type 2 diabetes, randomized them into two groups, standard Korean Diabetes Association diet or a low-fat plant-based diet. And there were no medication changes, and let's see how people did. Now, the first row there shows the changes across the board. So we see the plant-based group, the A1C went from 7.7 to 7.1. In the Korean Diabetes Association diet, there's a much smaller drop, 7.4 to 7.2. But then the group said, not everyone was equally compliant with the diet. Let's look at the group that was the most compliant. And then they saw even more meaningful changes there, where the A1C dropped from 7.5 to 6.6 in the plant-based group, and there was still a small drop in the KDA group. So hopefully this will answer the question you asked, Dr. Rima. Why does this work? Why do we say plant-based? Why do we say low-fat? So this is based on research that was done, that we did in collaboration with Yale University School of Medicine, where healthy volunteers were given glucose infusions, and then they had MR spectroscopy to look at their cellular fat content, to also evaluate their insulin and glycemic responses. And what we see here is a cell. This is just a muscle cell in our body. And those pink dots are glucose molecules. Now we know that glucose can't just enter our cell. The cell is very tightly regulated. So there's a channel through which glucose enters. And after we eat, our glucose levels rise, our pancreas produces insulin, and insulin comes along and provides the key to open this channel. So glucose now enters the cell. And this is how normal physiology is supposed to work. But what happens if we consume a high-fat food like fish or chicken or oil or ghee or coconut oil or cheese? What all of these foods have in common is their fat content is very high. So the lowest fat content might be in chicken white meat, but that's still 23% fat in calories. Fish, 50 to 70%. Cheese, 70%. Oil, butter, and ghee are 100% fat. And this is important because when we consume a high-fat meal or when we carry excess body fat, the fat enters the cell and it leads to insulin resistance. So even though we are now producing insulin, pancreas is churning out insulin, the cell is just resistant to it. And this is what sets the stage for prediabetes and eventually diabetes. However, this process can be reversed. If we can cut out the fats from the food, or if someone can reach a healthy body weight, the fat content of the cell goes down and the insulin sensitivity is restored. And then we can see normal glycemia. Now, we know that in people with diabetes, they don't really die of diabetes. What do they die of? Cardiovascular disease. They have an exceedingly high risk of cardiovascular disease. Can we reverse cardiovascular disease? Let me share some research data with you. This was a study called the Lifestyle Heart Trial. It was done by Dr. Dean Ornish at the UCSF School of Medicine. The results were published in JAMA and The Lancet. And what Dr. Ornish did was he recruited participants with known cardiovascular disease. And how did they know people had cardiovascular disease? They had been clinically diagnosed. And then they randomized them into two groups. One group got usual care. The other group got lifestyle intervention, which comprised of a low-fat vegetarian diet, moderate aerobic exercise, such as half an hour of walking, stress management, smoking cessation, and group support every week. And then people were followed for 5 years, but then they did something else. Everyone got a baseline angiogram, and then another one at 12 months, and then another one at 5 years. So these were very brave people, 3 angiograms. And let's see how they did. So at 1 year, the lifestyle group had lost 11 kilograms. The control group had actually gained 2 kilograms. Now, this study was done before statins became the standard of care in cardiovascular disease. So, despite not getting statins, the lifestyle group dropped their cholesterol 62 points. This is a huge decrease. We may not even get that with statins alone. And the LDL cholesterol went down 57 points. And then when they repeated that angiogram at 5 years, the researchers noted that there was actually a 4% reversal in the blockages of these coronary arteries in the lifestyle group. But in the control group, the blockage had actually increased 11%. Now, 4%, let me go back. 4% may not seem like a big reversal, but when we're talking about coronary blood flow, it is quite significant. Because, and we see that the number of cardiac events halved in the lifestyle group compared to the control group. This research study was published from Harvard last year, and it looked at the role of plant-based diet in decreasing the risk of chronic disease. And what they found is that a healthy plant-based diet is associated with a 21% decrease in the risk of type 2 diabetes, 15% reduction in the risk of cardiovascular disease, 13% reduction in cancer incidence, and 14% decrease in all-cause mortality. So really significant. This is just by changing the way we eat. Now, a team from Harvard published this study also a couple of years ago, and they looked at the role of plant-based diets in South Asians in the US and how that plays out, because they said we're seeing this paradox where South Asians, about 40% of them are vegetarian, yet they have a higher incidence of cardiometabolic conditions. So what is going on? And so they wanted to tease out, is it the type of vegetarian food that makes a difference? And that's exactly what they found. So they classified the food into 3 groups as healthy plant-based foods, which were whole grains, fruits, vegetables, legumes, herbs and spices, nuts, tea, coffee. So very similar to that power plate I showed you, very similar to the food that the research participants were advised to consume. Then they made another group, less healthy plant-based foods, refined grains, deep fried snacks, pickles, potatoes, coconut, sugar-sweetened beverages, sweets and desserts. And then the third group was animal foods, which was milk-based desserts, dairy, butter, ghee, cream, egg, fish, meat, and other animal foods. And what their analysis showed was that participants who were consuming this first group, the healthy plant-based foods, they had a lower incidence of prediabetes or diabetes. They tended to have lower A1C levels, lower body weight, lower BMI, less hepatic fat. And again, the hepatic fat was measured with CT scans. So currently in South Asia and in India, we're surrounded by foods that are high in calories, low in nutrients, but we can reverse this by going back to the foods that we traditionally ate that we already know. Legumes, whole grains, vegetables, not frying the food, but eating it in its more natural form. Now I'm going to go through a pop quiz and get your thoughts on a few things. All right, this comes up quite a bit. So true or false, how many people think plant-based foods may not provide enough protein? Can I get a show of hands? Yeah, some people. How many people think it's false? How many are not sure? Yeah. So before we can answer that question, we need to ask, how much protein does our body need? And the answer is about 10 to 15% of our calories should come from protein, and that's it. Right, it's 0.6 grams per kilogram of body weight, which comes out to about 10 to 15% of our daily calories. That's right. Now, most people aren't going around figuring out, okay, this is my body weight, this is how much protein I need. That's really not practical, right? Although we use it in research studies. So this is a good rule of thumb that you can use. So I said 10 to 15% of our calories need to come from fat. So how much protein do plant-based foods have? Fruits, 2 to 8%. So if someone is just eating fruits, they're probably not getting enough protein. But add the grains, and they're 10 to 17% protein. Vegetables, 10 to 50% protein. Spinach is 50% protein. Even onions, which nobody thinks of as a health food, are 10% protein. So vegetables are loaded with protein. Legumes, 20 to 45% protein. So this is where our Indian dals, chana, rajma, they make a huge difference. So you can see on a plant-based protein, plant-based diet, we can easily meet our protein requirements. Okay, true or false? Dairy products promote health. How many people think it's true? Okay. How many people think it's false? There are many health risks actually associated with dairy. Dairy is associated with increased inflammation and autoimmune conditions such as allergies, asthma, acne, increased risk of cardiovascular disease, increased risk of type 1 diabetes, increased risk of autism, increased risk of cognitive decline, increased risk of breast and prostate cancer, and poor gut health, so higher rates of constipation. Now, dairy is often touted for protein, but I already showed you how we can get all the protein we need. It's also touted for calcium. What do we think? Is dairy essential for calcium? Can I get a show of hands? How many people think that's true? Yeah, how many people think that's false? All right, let's look at this data. So the first question is, how much calcium do we need? I don't think anybody knows, because if you look at these recommendations from expert groups, they are all over the place. The World Health Organization is saying 500 milligrams. The UK is saying 700 milligrams a day. And in the US, we're recommending 1,000 to 1,500. And let me add to this, meta-analyses have shown that dietary or supplemental calcium does not impact bone health. There are other factors that are much more important. Having said that, we do need some calcium. And yes, dairy does provide calcium, but so do a lot of plant foods without all of the other risks that come with dairy. So a cup of soybeans, 261 milligrams of calcium. Chana, 109. Sarso saag, 165 milligrams. So we can easily get our calcium from these plant foods along with fiber and antioxidants that come with them. And there's another problem with dairy, lactose malabsorption. So worldwide, the incidence of lactose malabsorption is about nearly 70%. So when we're born, we do produce the enzyme lactase, which helps us digest lactose that's naturally found in milk, including breast milk. But after the age of weaning, the levels of lactase go down because we simply do not need lactose or dairy in our diet anymore. And that's when people start developing issues with dairy. or any lactose product. And in India, the estimates are that 60% of Indians suffer from milk intolerance. So it is a big problem in India as well. Are you familiar with A2 milk? How many people have heard of that? So A2 milk has been touted as potentially a healthier alternative. So let me just go through that with you. What are A2 and A1 milks? So beta-casein is a protein that's found in dairy milk, okay? It accounts for 30% of the protein in dairy milk. There are two types of beta-casein protein, A1 and A2. So some people have proposed that, and let me go back a little bit. Beta-casomorphine, BCM7, is produced from A1 milk, but not A2 milk. So some people have proposed that the problems with dairy have to do with BCM7. So if we could just switch to A2 milk, we could avoid these problems. Most commercially available dairy milk has both A1 and A2 protein, but A2 milk is available. Now, so while this hypothesis has been put out there, what does the science show? So research has shown that when it comes to lactose intolerance, it doesn't matter what kind of milk it is, A1 or A2. The issue doesn't change. There's still lactose. A2 milk, there's no research to support that A2 milk decreases inflammation in the body. There's no research to support that A2 milk is associated with a lower risk of type 1 diabetes or lower risk of cardiovascular disease or cognitive decline or autism. So while these claims are made, the science isn't there to support them. Okay, this is a big one. What about ghee? Does ghee promote health? What do we think? True or false? How many people think it's true? Okay. How many people think it's false? So let's go through this. So what is ghee? Ghee is basically extracted from fat from dairy products. Now, this research study came out of Iran where they randomized people. They did a crossover randomized trial. So people were initially randomized to consume either ghee or oil every day. Then there was a washout period, and then they went to the other side and consumed the other product. And they wanted to see how this impacts their health. So what did the research show? It showed that compared to olive oil, ghee consumption was associated with an increase in apolipoprotein B levels, higher levels of non-HDL cholesterol. Now, we know that research has shown that higher levels of apolipoprotein B and non-HDL cholesterols are associated with higher risks of cardiovascular disease. So when we're looking at ghee, the data supports that it is the saturated fat content of ghee that is thought to be responsible for this, and the cholesterol that's naturally found in ghee. Okay, what about this one? Coconut oil is a health food. How many people feel that's true? Yes. How many people think it's false? All right, let's look at the research data. So this study was published in the journal Circulation, looking at the effect of coconut oil consumption on cardiovascular risk factors. This is a systematic review and meta-analysis of all clinical trials that were done on this topic. And what the research team concluded was that compared with non-tropical vegetable oil, so tropical vegetable oils are palm oil, coconut oil, because these products are found in tropics, and what they both have in common is they're high in saturated fats. That's why they're solid at room temperature. So compared with non-tropical vegetable oils, coconut oil consumption significantly increased LDL cholesterol by 10 points. It also increased HDL cholesterol by 4 points. However, it's important to appreciate that increases in HDL cholesterol have not been associated with a decrease in cardiovascular disease. So when we look at recommendations for lipid-lowering therapy, they're all targeting LDL cholesterol levels, not HDL. And the editorial that accompanied this piece, there was an editorial that accompanied this with a researcher from Harvard, and he went on to conclude that coconut oil may be perhaps the most harmful oil when it comes to frying, and it's best to minimize it completely. Now, has anyone heard that maybe soy can cause breast cancer? Yes. So there is some people are often concerned about soy and breast cancer. So where does this come from? This is not true. It's actually false. Let me explain. The reason this concern came to be is soy products contain plant-based estrogens called phytoestrogens that are found in many plant foods. So people were concerned that these phytoestrogens could increase the risk of breast cancer, just like pharmaceutical estrogens or just like our own estrogens that we produce. However, what research has shown is that the estrogens that we produce or that we ingest from medications bind to a different receptor than phytoestrogens do. So the receptor with which soy binds actually decreases breast cancer incidence. So research has shown that the risk of breast cancer is decreased in women who consume more soy, and even in women who've had breast cancer, the risk of recurrence decreases. And soy also is associated with less hot flashes. Yeah, so what would the concern be about men and boys consuming soy? What is your concern? Maybe in this fat, gynecomastia, yeah, so that has been a concern and research has not shown that. So gynecomastia is abnormal breast tissue development in men, and that has not been found in research studies. Most men, when they're developing what appears to be breast development, it's actually not breast tissue, it's actually fatty tissue related to body weight. Yeah. So it's completely safe for boys and men to consume soy. Yeah, I have a few more. Okay, so I'll finish, then we'll come back. And soy also improves bone health and is a great source of protein. Okay, are keto diets familiar to you? So they're gaining popularity and they've been touted as a heart healthy diet. They're popular because they help people lose weight rapidly. However, the weight loss doesn't last. The problem with keto diets is they're actually associated with a higher risk of heart disease, according to latest research findings. And what are these diets? They're high in fat and protein and very low in carbs. And when people cut out the carbs, they're cutting out fiber, which is essential. So they're missing out on the health benefit. And their health effects are quite concerning. They increase total and LDL cholesterol levels. They increase the risk of cardiovascular disease. And they increase the risk of death. So just some practical tips. Plant foods are actually quite familiar to us. They've always been a part of our culture and tradition. We just need to revert back to the way we used to eat. So flavoring our food with traditional spices and herbs instead of added fats. So skipping the ghee, cream, oils, and using herbs and spices instead. And air frying instead of oil frying. Air frying is a great way to make food crispy and crunchy without any added oil. So you can do air fried samosas, air fried aloo tikkis, and try air fried golgappas. They are amazing. And then instead of deep frying the food, we can have our traditional roti, which doesn't have to have any added oils or fats added to it. And then there are plenty of non-dairy products that are readily available, and they're naturally low in saturated fat and cholesterol free. Soy, almond, cashew, peanut, there's so many out there. And that's palak paneer that I made with air fried tofu, and then that's cucumber raita with soy yogurt. And just some tips for you all to experiment with. And some more as far as desserts and dairy alternatives. And then I just wanted to end with B12. This is an essential vitamin that we need. We cannot produce. We must get it from our food, or we must ingest it. As you all know, it's essential for nervous system and the blood. The recommended daily allowance is quite small, just 2.4 micrograms a day. We can easily get that from a 100 microgram supplement. It is water soluble with virtually no toxicity. I just wanted to share some clinical programs we launched. This is an online weight loss program that I launched during the pandemic. That was 12 weeks. We met every week through a Zoom meeting, and we guided people in helping lose weight. We've had over 700 people participate in it. So sometimes it's hard to do nutrition coaching in an office visit, but group programs could be an effective option. This was our class format: checking in, education, cooking demo, and then Q&A. These are some free resources that I would like to share with you from our organization. This is an online diabetes program that we launched during the pandemic. We had over 20,000 registrations. It's 8 weeks, and anyone can go online and watch the recordings. Really helpful information. We have online recipes that you can download at no cost. And I will stop right there and take any questions you have.
Studied scientifically within clinical outcomes. Vanita has been shown to be cardiovascular and reduce major cardiovascular events. So I would not share it completely with diet. And then the distribution that you say low fat. And if you look at the AIIMS survey, we eat 80% of our macro calories come from carbs. I think that largely drives on diabetes, which drives the cardiovascular disease epidemic. So that's something where I would really differ. I think we're already very low on oils and proteins, and our diets should modify to include more of these and go low on carbs. The other thing you mentioned, again, the dairy, but there's again no evidence that dairy increases cardiovascular disease. There are large metabolic, and if you look at guidelines from European or the American Heart Associations, they do not talk ill of dairy. So I think moderation is the key in any dietary advice. And the last would be, I think, if you see increasingly, whether it be cancers, cardiovascular disease, strokes, is related to the inflammation in the diet. And how do we reduce, how do we have a low inflammatory diet? And it's, something called the dietary inflammatory index, which is the most widely studied objective way of studying diet. And this best correlations with cardiovascular and cancer outcomes. And it's through multiple groups. So it's not that one group is producing that data. There's a lot of meta-analysis. And that's clearly showing that if you reduce the inflammatory components, which essentially comes from herbs and spices, which thing we should be promoting. So I'd like to just have your thoughts on this.
Thank you for your feedback. So a couple of thoughts. You mentioned the Predimet study. This was a large study done in Europe looking at a Mediterranean diet in preventing stroke, cardiovascular disease. And what it showed was there was a decrease in the risk of stroke, but there was no decrease in the risk of other cardiovascular events or mortality. And when we look at the PREDIMED study, this was not a low-fat diet. They were consuming a diet high in fat. It was about 30 to 40% fat. When you look at Dr. Dean Ornish's study, the Lifestyle Heart Trial, that was actually a low-fat diet using mostly plant-based foods, and they did find a decrease in cardiovascular events all around, and a decrease in cholesterol. I think your point about the Indian diet being high in carbs, I think it really depends on the carbs we're consuming. So if the diet is comprised of whole wheat, brown rice, millets, ragi, that is fruits, vegetables, those are complex carbohydrates. But if the diet is made of maida, white rice, fruit juice, or deep fried vegetables, then the complex carbohydrate benefit is lost. And we're looking at foods that are very processed, high in sodium, high in added fat. So it really depends. And that's what the Harvard study was looking to tease out. That why is it when South Asians are 40% of them are vegetarian, why is it that their risk of cardiovascular disease is higher than most populations? And that's what they found is it's really the type of vegetarian food they're consuming. So we really need to separate that out.
Exactly. So that binary of, in fact, if you see the masala, the vegetarian diet was not protective. So it's not the veg versus non-veg or a dairy, non-dairy. It's the overall quality of the diet which we need to look at. And the lifestyle Dean Ornish trial was not powered to look at cardiovascular events. So they did not really, was not powered enough to look at events. So you have only one trial, PREDIMED, which is looking at hard cardiovascular events. And as evidence-based medicine people, we need to respect that.
Yeah, well, the Lifestyle Heart Trial did look at cardiovascular events, and they saw the event rate was half at the end of the study.
But it was not significant. They're all surrogate endpoints that they were looking at.
I believe it was, but we can take that offline. Yeah.
Anybody else, please?
Moderation is the key. What I'd like to know from you is it's fine for adults to have a plant-based diet, but is it advisable for growing children to only have a plant-based diet? Is it healthy for them?
Yeah, absolutely. The American Dietetic Association has said that plant-based diets are healthful at all ages of life, from
But
pregnancy.
are they good enough for promoting, increase in height and, that's
Yeah.
what children, that's the conventional wisdom, that children need calories also, and the growing children would need dairy, for example, not just for calcium, but for protein. Now, for protein, you said there is sufficient amount of protein. I agree in plant-based diet. But it's the quality of protein also which matters. And we can do supplementation. Supplementary protein concept I do understand. But the essential amino acids which are present in dairy products are not present in dals and plant-based diets. So for growing children, I wonder whether this diet will work.
Yeah, research has shown that this diet is appropriate for all children at all ages. As far as protein, plants provide us with all the essential amino acids we need. And animals also get their essential amino acids from consuming plants. So all we're doing is cutting the animal out and going directly to plants. So we can get all our essential amino acids. We don't need to take protein supplements. In fact, I don't recommend them. And for children, the only difference I recommend for children is they don't necessarily need to keep it low fat. So with them being more liberal with nuts and seeds and avocado because they're growing, they can accommodate those calories more. But otherwise, they can get all the nutrients they need. And of course, they should also take a B12 supplement.
Children, growing children.
Yes, B12 supplement. And children don't like to take pills, but they're available as gummies that they can chew, or you can just spray their mouth with it. It's readily available. Yes.
Good afternoon to all of you. Yeah, very nice presentation. You have covered all aspects regarding obesity and metabolic diseases reversal. And even you have covered cancer, which is a cause of concern in India today. Rising incidence of breast cancer, even polycystic ovarian syndrome in this the plant-based diet seems to work well. But what I would like to say is that nutrition is a young and evolving science, and we have a long way to go before making any going for public health approaches regarding the nutritional strategies. We have to keep in mind the traditional eating habits, and we can modify a little bit around that. That is very important, because affordability is very much important, availability is important, and so it should be sustainable also. All these things are very important, because people who are living in the coastal regions, fish is available there. And if we tell them not to have fish and only have plants-based diet, then it is not the right thing, because it is available and it is a good source of, it has a lot of nutrition in that. So telling a person not to have a particular food which is available, easily available in a region, should not be the policy. And nowadays we have precision nutrition, personalized nutrition. That science is also growing. And in this science, we also study the genetic composition, then microbiome, metabolome, and nutrigenomics, all the environment, all aspects are covered. So whenever we are prescribing diet, we should cover all the aspects in total. So I feel this is more important. Although we are bombarded with lot of diets, Mediterranean diet, DASH diet. For this, if we want a person to comply, education and awareness is very important. Until and unless a person is aware about the various food groups providing various nutrients and what foods to target for a particular nutrient, a person will not get a balanced diet. So education and awareness is important, and we should look for a diet which is affordable, easily available, and sustainable, and environment friendly. So this is my take.
Yeah, I'm so glad you brought that up, because I think that's so important. You know, we shouldn't even be calling it a diet. We should be calling it a lifestyle, because a diet is something we do temporarily and then we stop and then we go back and then our health goes back to where it was. So the nice thing with eating plants is our traditional Indian food is plant-based. You know, it is full of legumes and vegetables. Those foods are actually cheaper than animal products. And when it comes to environmental sustainability, research has been very clear on this, that animal agriculture creates a lot more greenhouse gas emissions than plant-based agriculture. So, and we know that air quality makes a big difference in all our health. It impacts cardiovascular mortality, lung disease. So I agree, all these things are important. And another thing I wanted to say is we never tell people what to eat or not to eat. That is not our role. We just present the scientific research to them, and then we let them decide. You know, when I spoke to my patient about her options, I didn't tell her what to do. I said, these are your options. Here are the risks, here are the benefits. What would you like to do? Because you get to decide. This is your health. And that is what she wanted. And that's what we do in our research studies. We tell people, these are the benefits of eating this way. If you would like to participate and you're able to comply, then you may enroll. But we never tell anyone what to eat or not to eat. We let them make those decisions. Yeah.
You know, I had another question, like, yes, there were many things which were set right in my mind, because I'm a big foodie and I've been going to Dr. Parmeet many times to get certain concepts right. And if we could just lose weight by a plant-based diet, I think I would have lost lots of it, which I haven't lost. And I still can't figure out whether I have to decrease carbs or fat. And I, for one, always thought that having maybe a small piece of a coconut every day is good, because it helps to prevent Alzheimer's. It has lauric acid, and avocado is good. And though we can't afford avocado every day, and it's not part of our diet, but coconut is. And rather than having oil, somebody told me eat it rather. And also, I think a lot of things that we are consuming today, even through the information that we are getting, it's how the cows are reared, whether they've been given these injections, whether they are an animal, these farms where they are reared, or whether they are the desi cows and their ghee is good. Because I've seen our parents are healthier than us and they are consuming a lot of dairy and they are consuming ghee daily. Though I keep on bombarding that with this information that don't have too much milk because it has IGF, and also they tell me don't give us this information. हमारी जिंदगी ठीक चल रही है. So I sometimes wonder कि whether we are right or is it that we do have to live in moderation. And I totally agree with Dr. Ambuj. So would you clarify whether it's carbohydrate or fat that we really need to look into?
Well, I let the research speak for itself. So all the research studies that I shared with you, that the macronutrient breakdown was what I showed, which was 80% carbohydrates, 10% fat, 10% protein. And that was shown to lead to these helpful health outcomes. Now, Dr. Christopher Gardner at Stanford did do a research study looking at a low-fat versus a low-carb diet. And he published that in JAMA, and I published comments to that in JAMA. And he found there was no difference, but I took exception to his conclusion because this wasn't a low-fat diet. The low-fat diet was 30%, the high-fat was 40%. So they were both really high-fat diets, so we can't draw any conclusions. But all these research studies I shared with you, they were consuming a low-fat diet, and these were the outcomes they had.
The group of people who are, in India, I was just reading a study the other day. These are children born to undernourished, malnourished mothers. And their children tend to develop diabetes because their genotype tries to conserve every calorie because how their genotype has been modified by their epigenome. So how can you prevent that?
Well, I think in India we have two aspects of malnutrition. There's the kind where people don't have enough to eat and there's starvation. Then there's the other kind where there's excess of food, and that's leading to obesity and related complications. So India, like many developing countries, is facing both. Now, for the person that you're describing, someone with limited means and their children don't have enough to eat, they may develop diabetes because it's based on what they're consuming. What are they being given? Maybe they don't have the money to buy foods that are wholesome and nutritious, and they're maybe just being fed limited foods that aren't as nourishing, and that may be impacting them. So it's really hard to say. We'd have to look very carefully at that child's diet to see what's going on to determine the risk and whether it's type 1 or type 2 diabetes that they're developing.
Just to add to what you were asking, Dr. Rima, that's more of a birth cohort. It's part of the New Delhi birth cohort that's published from our department. But there's that rebounds of adiposity which happens in the first 2 years of life, which leads to much higher diabetes and cardiovascular. That's the Barker hypothesis, and it's been tested in multiple birth cohorts now, including the Indian cohort. So it's where you're born underweight, and if you rebound to have much increase in your weight in the first 2 years of life, those children, those infants go on to develop much higher of diabetes. Probably they were engineered in their wombs to have, and they've been shown to have less of beta cells and those kind of things. So it's that way they're engineered to have low insulin productions. So that's what has been shown in the studies which have been shown.
Good presentation, Dr. Vanita, and I agree with Dr. Ambu sir and ma'am. My only two observation, like your patient which you have shown in the first presentation, your patient might be sarcopenic as well. And for sarcopenia, the protein requirement is quite higher than the 0.6 gram protein per kg of body weight. The second thing you have shown about the ghee consumption, but you haven't shown the baseline physical activity level among those patients and what amount those patients were having in that particular group.
Can you ask me the question again?
The two observation. In your first presentation where you have given a case presentation, your patient may be sarcopenic as well. You haven't shown the muscle loss after 1 year of follow-up. which you have shown in your these things. And the protein requirement for sarcopenic patient is not zero 0.6 gram. That is higher than the double, that is double the amount which you have mentioned. And the second thing is, like you have shown in your presentation, that ghee consumption is like detrimental for people, but you haven't shown the baseline physical activity level among those groups, and what amount they were having at those in those periods.
Okay, yeah. So let me, my patient who lost weight and reversed her diabetes, the only way to know if she lost muscle or fat is to do an imaging study. So that would be a DEXA scan or CT or MRI. Body caliper measurements are not accurate, nor are other tests. And usually we do not do those tests unless it's part of a research study. They would not be covered by health insurance. They would not be clinically indicated. And for the most part, it isn't necessary. She could have paid out of pocket and gotten it done, but she was feeling so much better and now walking 3 kilometers a day and losing weight. So, it's hard to know if there was any sarcopenia there because she improved rapidly. In that Iranian study with ghee versus olive oil, it was a crossover study. So the same people initially consumed ghee, and then they stopped for 2 weeks, and then they switched to olive oil. So their physical activity wasn't different. Their overall caloric intake wasn't different. Everything else was the same. The only thing was, and I believe they were consuming 1 or 2 tablespoons of ghee or olive oil each day. That was the only difference. Yeah. Oh.
Hello, ma'am. Just have a hello.
Oh, I think he's.
First, let me compliment Dr. Vanita Rahman for an extremely clear, evidence-based talk, and at the same time keeping it simple, which is not easy to, if you want to present with the help of research data, to at the same time keep it so simple so that everybody can understand, including people who have been out of this field for some time, is not easy. And along with that went some very beautiful slides, which could be a lesson for anyone about on also how to make good slides. I'll make a few comments and then maybe a couple of questions. One comment would be on the reversal of cardiovascular disease in teen Warnish study, in which it was shown that those who were on the lifestyle modification group had a reduction of 4% in the obstruction of the coronary arteries, in contrast with the control group, which had only conventional care, in which the obstruction went up by 11%. And as was quite rightly pointed out, 4% reduction is not big, but it is significant for coronary blood flow. Not only is it significant from the point of view of coronary artery blood flow, it is significant from another point of view even more, and that is, it was a paradigm shift. Because when I was a medical student, we grew up with the idea, the general impression, that it's only acute diseases like common cold and diarrhea which are self-limiting. For chronic degenerative diseases, we have no self-healing mechanisms. Generally, they keep getting worse. Maybe in some occasional cases, with great effort, they might stay the same. But that they could reverse, that we have self-healing mechanisms even for chronic disease, was something which was unthinkable. So even this 4% reduction was therefore significant. It was a paradigm that we have self-healing mechanisms inbuilt into the body, even for chronic disease. When it came to nutrition, which was what was mainly presented today, there are just a few comments. If I had heard the same talk 20 years ago, I would have agreed with 100% of it. Today, I might agree only to the extent of 75 to 80%, of course, leaving scope for the fact that neither I nor anybody else can claim to know the total truth. There's always room for doubt and discrepancy, even when we are presenting research data. Because sometimes the research studies may be flawed, sometimes the number of research studies may be inadequate, sometimes the research studies themselves may be controversial, And there may be some aspects of nutrition which are beyond the scope of research. So some doubts will always remain. But why I'm having some doubts today as compared to what I might have had 20 years ago is because of having got a bit into traditional Indian wisdom, particularly as shrined in Ayurveda. And on that basis, a few points that I would make is, very briefly, because naturally it's not a session on Ayurveda, and it is not my talk. Firstly, that modern scientific nutrition does not take into account individual variation. It's one size fits all. Secondly, it does not take into account seasonal variation. The dietary, what would be an optimum diet varies also with the season. And there's an interaction between the individual and the season, so that some individuals may need greater attention during some seasons to stay healthy. Thirdly, what we do not have in modern scientific nutrition is the concept of what Ayurveda calls satmya. Satmya ho jana, which means get accustomed to it. So even if somebody has been violating some principles of proper nutrition, including the principles of Ayurvedic nutrition, but he has been doing it for decades and his body has got used to it, then it is said that for that person it is okay. Satmya ho gaya hai, this now person has got adapted to it. And that may apply to things like coconut oil, for example, in Kerala. Because there are studies which have shown that in spite of high coconut oil consumption in Kerala, the incidence or the prevalence rather of cardiovascular disease is not very high. To some extent, that may apply to population as a whole, Indian population as a whole, when it comes to things like ghee and milk. But then on the subject of ghee, again, one can't equate all fats. And after going through that phase of obsession with polyunsaturated fats, particularly N6 polyunsaturated fats in the 1960s or so, by the time it was 1990, we had in modern science also settled down the idea that we should have not more than 30% of the calories from fat, 1/3 saturated, 1/3 unsaturated, monounsaturated, 1/3 poly, and within poly, the ratio of N6 and N3 became important. So that much moderation we had. But then even within saturated, all saturated fat is not alike. And ghee is not 100% saturated, it's only 65% saturated. And we did a study on ghee in around the year 2000. I think one of my MD students did it. I think it was published in the Indian Journal of Physiology and Pharmacology in 2005, where we had shown actually a favorable effect of ghee. So if one goes into all the research studies available, one will end up with at least some controversy, if not a clear-cut conclusion. We'll reach some sort of a moderate, some sort of a doubt. So need for further research. And now coming to questions, one of them is about the 81% of South Asians having dyslipidemia. Now, how many have dyslipidemia can easily be shifted by just changing the cutoff point for normal cholesterol levels. And one cannot be sure whether determining these things like what is the cutoff for normal blood pressure, what is the cutoff for normal blood sugar, what is the cutoff for normal cholesterol levels, that has been shifting over the last few decades. And there is a suspicion, not entirely without reason, that there may be a pharmaceutical lobby behind it. Once you shift that, suddenly the percentage would go up. So how much the statin lobby is responsible for 81% dyslipidemia, one can't be sure. Secondly, about the muscle mass. One way is that since we have less muscle mass, more visceral fat. Now, in anything which depends upon percentages, if one is low, the other will automatically be high. Now, is the solution that we go on shifting the BMI cutoff, which determines the risk factor for Indians or Asians as compared to the Western populations? Or does the solution lie in being physically more active so that our muscle mass goes up? Once the muscle mass goes up, the percentage of visceral fat will automatically come down directly as well as indirectly because of other lifestyle modifications. And the result perhaps would be that our BMI cutoff may not remain 23, it might shift a little upwards. So our BMI cutoff could shift just by increasing the muscle mass through increased physical activity. And another thing I think which also one naturally can't have everything in a single session, but I think one thing which got neglected was the psychological factors, importance of psychological factors, which again have an overriding influence on development of chronic disease. And one question about gluten. You know, the obsessions keep changing, and these days there seems to be one of the obsessions with gluten-free diets. I don't know what your opinion would be on that.
Yeah, thank you. Thank you so much for your feedback. Yeah, I think gluten-free it's not uncommon to see fad diets making their way in nutrition. We've seen this, the liquid diet, the keto diet, the South Beach diet. These are all fad diets, and they're fad diets because they work temporarily, but they're not sustainable and they don't have much scientific evidence to support them. But people like them because they can get quick results. Of course, the results are not sustainable because the diet is not sustainable. I am concerned that gluten-free is falling into that spectrum. There are people who cannot digest gluten. Gluten is the protein that's found in wheat and some other grains. And there's a condition that, as we all know, it's celiac disease, where people cannot digest gluten. Exposure to gluten leads to inflammation in their intestine and a slew of malabsorption and other problems. However, celiac disease has to be diagnosed with an intestinal biopsy and blood testing in the appropriate clinical context. Too often, gluten-free foods are being promoted for health, and people are avoiding them when they don't need to. And when they're avoiding them, they're missing out on these essential grains that they could benefit from because they're substituting gluten with something else that may not be as nutritious. So I think it is important to be cognizant of that. So I think that is important. I've even seen gluten-free shampoos in the US. How could that possibly affect someone unless they eat the shampoo? And nobody does that, right? So it's become this, it's marketing. That's what it is. Yeah. I'm sorry, I can't hear your question. Do you want to come to a mic?
When talking about proteins, animal and plant protein, what is your say on PDCA score? We generally say that animal protein is not 100, but 90 to 100% absorbable. But when coming to the plant protein, it is said that it is 70 to 80% only absorbable by human body. So coming among pediatrics, we need higher amount of proteins, and how can we reach that amount of protein for a pediatric child coming from plant-based protein?
So, I mean, all these research studies, people were getting plant-based protein and they were experiencing health improvements. So we know they were getting all the nutrients they needed and none of the ones that were harmful, and their health was improving. And in studies that have been done in children, there have been a lot of epidemiological studies done in children looking at plant-based diets, and there have not been found any concerns about protein deficiency in children who are consuming plant-based diets.
Okay.
I think I just wanted to add to that. Like you're saying, a plant-based diet, the bioavailability is less, but it's how you cook the plant-based diet that actually determines the protein that is available, right? Overcooking destroys the protein content.
Just 1 minute on this. I think this protein part is really important, and a lot of misconception continues, and that probably it's rooted maybe 70, 80 years ago when Cecily Williams did some studies in South Africa where she showed the importance of protein in kwashiorkor. And let's not forget that the African diets were cassava-based diets which hardly has any protein. Now, having said that, that somehow impression has persisted, and it has again been perpetuated by the manufacturers of protein supplements. That also is true. Now coming to the basic facts. Number one, when this young pediatrician says that the plant protein is digested only to the extent of 70%, I'm not sure where she got the data from. It may be that somebody had included in it all the dietary fiber, and dietary fiber is not absorbed. That will bring down the availability of any nutrient. But at the same time, if you do not do that, the fecal energy content by the conventional methods usually is just about less than 5% of the energy intake, which means more than 95% of whatever we eat, including plant protein, actually does get absorbed, number one. Number two, the second important thing is that when it comes to amino acids, again, because shortage of time, I think Dr. Vanita Rahman glossed over that fact. And she said you can get all the essential amino acids from plant proteins or animal proteins. It's true that you can get a good balanced supply of all the essential amino acids from animal proteins, not from cereal protein, not from pulse protein. But if you combine the two, you can get good quality protein because cereals are in general deficient in lysine and pulses in methionine. And therefore, when you put the two together, you get they complement each other and one gets a good quality protein, and which is in turn supported by research studies which go somewhere to the 1930s and 40s at NIN. They showed that if you combine cereal and pulse protein, you get the same rate of growth in growing mice, and I'm sure that applies also to growing children, and traditional wisdom as well as observations on populations like the Indian population support that. And that is how this combination is so good, that is how many traditional cultures reach this. In India, whether it's the north or the south of India, we have cereal pulse combinations. In China, we have rice and soybean, and in Latin American countries, we have corn and beans. So many traditional cultures have reached this cereal pulse combination through trial and error. Now, next question, especially for the pediatricians, children. Now, what we forget is that you need, say, about 10% of the caloric intake through protein. So if you have a combination of cereal and pulse, cereal about 10% protein, pulse is about 20% protein, forget soybean, which has 40%. Most of the others have 20%. If you combine the two, and that is your staple diet, it will automatically have more than 10% of the energy intake coming from protein. And therefore, it will be adequate. But it will be adequate not only for adults, it will also be adequate for children, because children not only need more protein on a per kilogram body weight basis, children also need more energy on a per kilogram body weight basis. So the percentage of energy that they need from protein remains exactly the same, 8 to 10%, which is in adults. So you can feed as a supplement khichdi to the child, and still you can have the same effect as if you give any protein supplement or animal protein only. So therefore, neither for children nor for adults, we need any exotic protein or animal protein to meet the protein requirements.
Should we take out dairy entirely from the diet of children? That was my concern.
Well, if you just take a step back and you think about it evolutionarily, dairy milk is a great source of nutrients for a developing calf. It was not designed for the human child. We adopted that practice, but we are the only mammal that consumes another mammal's milk. So evolutionarily, children were designed to consume breast milk until they wean from that and they transition to solids. That has been associated with healthier outcomes. Exposure to dairy has been associated with higher risks of all sorts of issues like type 1 diabetes, autism, and later on more complications. So it is not essential for us to consume dairy, for our children to consume dairy.
Your time is limited, but I would like you to elaborate how is consumption of dairy associated with autism? I'm
So
not
we
aware of
don't know. A lot of the issues with epidemiological studies is we don't know the cause and effect. We just
the mother consumes dairy.
well, we don't know. Again, with type 1 diabetes and autoimmune conditions, the theory has been that there are certain antigens that are found in dairy that we develop antibodies to. And then those antibodies react with our own tissue, and that leads to inflammation in our body. So that's
possible as a causative factor for a fetus.
so
The
as
mother consumes.
yeah, and especially with things like asthma, allergies, and acne. Acne is a big problem for teenagers, but eliminating dairy is very helpful. And then the other thing I want to point out is often the problem with children is they're getting a majority of their calories from dairy, cheese, milk, and they're not getting much fiber because they're just not hungry for other things. And then they're struggling with constipation. And we see that all the time in the clinic. So there are issues with dairy. It's a zero fiber food.
What I feel is that until and unless it is therapeutically recommended to eliminate a certain food, just to follow a particular diet, we should not be eliminating. Whatever is available and geographically available, one should be consuming. And nowadays we are having low-fat versions of milk available, and even the byproduct like yogurt, curd, they have a lot of nutritional value. So
Yeah,
I
what
think
about, what's your take on yogurt?
elimination is not the answer.
Hmm.
If
That's
it is
good.
available,
Curd.
one can always have. Yeah, yeah.
Sorry.
Even yeah. एक second.
Thank you.
Switched off. Just press it till it becomes red.
Okay, can you hear me now?
Yes.
So yogurt is a big part of Indian cuisine, of course. And when I went plant-based 12 years ago, that was the food that I missed the most. There are lots of good yogurt alternatives available. So soy makes a great yogurt, almond milk, peanut milk. We can readily find them. I was in Kolkata last year where we found almond-based yogurt. That was terrific. In terms of gut health, we have trillions of microbes that live in our intestine, and they eat what we eat, and they impact our health in all sorts of ways. Now, what we're learning is that the best food for them is fiber. That really helps promote the growth of healthy bacteria. So for gut health, we often find for people their health improves if they cut out dairy, because many people are lactose intolerant, and then they're getting those symptoms of bloating, indigestion, discomfort, and that improves after cutting out dairy.
May I also add to what we were talking about, kids and dairy intake? There are a lot of studies which have indicated that the incidence of breast cancer in women later in life is related to also consumption of animal products, which includes dairy. Because when we look at dairy, it's also in the contemporary times, in the last 50, 80 years, how much hormone content is there in that milk. So age of menarche in countries like the Western world, there was a study was done in UK and US, they had taken the populations. The age of menarche has come down, and also so overall exposure to estrogen for the woman has increased. So they had linked that to the cancer incidence, both uterine and breast cancer mostly. Whereas they said in countries, or rather regions, where animal products, particularly dairy, specifically dairy, was less, consumption was lesser, then age of menarche is higher, and overall exposure to estrogen is lower. And this is what this study was pointing out. So it's not necessary, according to that study, it's quite a popular study, I'm not able to refer to it right now. Dairy is not very advisable. I mean, it does have cancer risks and connections. Particularly when you look at the source and the kind of dairy that we all have, which has hormones, it has pus cells because of intense antibiotics given to cows because of over milking. So it has antibiotics. This is proven, several times over by many studies, by local bodies like CSC in India, and also larger studies which were conducted. So three things: antibiotics, hormones, and pus cells. So dairy does have a lot of this than what perhaps our parents' generation had growing up. Sorry, I had another question. Thank you so much for your presentation. It was very nice and very insightful, backed with tons of data. Towards the end of your presentation, you had referred to air fryers. Now, I had been looking at some studies which have pointed out that there is a link of cooking by air fryers and it leading to the food becoming more carcinogenic. I don't know, have you heard about, or is this?
Yeah, I'm not familiar with that. What we do know is deep frying is not nutritious because it adds a lot of fat and unnecessary calories. It takes away from the food's nutritional value. We're cooking it at a high temperature. We may be hitting the smoke point of an oil. So air fryers are a great alternative. You obviously don't have to use an air fryer. You can just do it on your stovetop too. But it's just an option for people who want that crispy texture.
Yeah, sure. Thank you. It was not necessarily in reference to comparison with deep frying, but in isolation. But perhaps I will research a bit more on that. Thank you.
Once again, I would like to thank you very much for coming here to our institute and presenting a very good presentation on a very important topic. And nutrition is the key buzzword of today's time. And we had a lot of information. We got very valuable information from you. And we hope to get connected with you in future also. And we'll close the session for today. And thank you very much for your esteemed presence, Dr. Bijlani. We are really very grateful. It's indeed a matter of great pride and honor that you have come to grace the occasion. Thank you so much, sir. Thank you.
Thank you so much for a very illuminating talk, ma'am, and a very healthy discussion that followed it. I would like to request Dr. Parmeet to give a potted plant to Dr. Bijlani as a mark of our respect. Let me tell you that he is the one who sowed the seeds for integrative medicine at AIIMS. He is the ex-professor and head of Department of Physiology. And now I request Dr. Ritu to deliver a vote of thanks. Thank you.
Good afternoon. It was a very illuminating, very enriching talk, ma'am. Just a few words here. The human race has strived for an existence which is endowed with comforts and leisure through the millennia. Unfortunately, now that we are living with this pot of gold at the end of a rainbow of tireless endeavor, all we have is fake tinsel. We are currently in the throes of a deluge of morbidities and infirmities which arise from a sedentary lifestyle and, most significantly, from our unhealthy food choices. In this scenario, physician and nutrition expert Dr. Vanita Rahman's talk on the central role of nutrition in preventing and reversing lifestyle diseases afflicting the present generations serves as a timely eye-opener for initiating the course correction which is needed, and also a welcome whistleblower exposing the mass subconscious manipulation orchestrated by the nexus of industry profiteers and advertising media. Your talk was informative, engaging, enriching, and empowering for us all, the battle-weary and dispirited fighters of the flab. We thank you, ma'am, for leading our way from darkness to light towards a healthier relationship with food. I would also like to thank our media head, Dr. Professor Rima Dada, for showing such avid interest in this crucial aspect of health and working diligently to organize this event for the general well-being of the AIIMS family, undeterred by the naysayers and detractors. As usual, Dr. Rima, your planning was meticulous and the execution was perfect. Thank you so much. We are very grateful to Dr. Bijlani for honoring us with his illuminating comments, and also I think he did a great value addition to the entire session. He clarified so many aspects which may have been, for reasons of time and brevity, been left out in the talk. And he also added on to, with his vast experience and knowledge in several aspects of science, Ayurveda, and healthful living. We are all indebted to our Honorable Director, Sir, Professor Srinivas, for unfailingly extending his constant support and active encouragement towards every such initiative that raises health awareness and has a transformative impact on habitual behavior. A word of acknowledgement for our wonderful audience comprising of students, faculty, members of the RDA, SYS. Your enthusiastic participation is much valued and appreciated. Finally, we are grateful to the Physicians Committee for Responsible Medicine, that is PCRM, for organizing the sumptuous treat and nutritious meal that we are about to enjoy next. I won't keep you waiting. Without further ado, let's just dig in. Enjoy the ride towards becoming the healthiest version of ourselves. Thank you.
We would like to express our warm gratitude for your lecture by this AIIMS plaque. Thank you, ma'am. Now, please join us for lunch in the adjoining dining hall. Thank you.